Well, thank you. It is such a joy to be here and to be a part of this conversation. Well-being metrics in 15 minutes, go.
Let's just say I'll frame this more as a conversation starter.
My one anxiety about coming into these 15 minutes was that there's so much to be said and so much to be brought to light and to discuss that I might not do the honor to each and every moment in this conversation. And so that's why I'd really like to frame this as a starting point. And also, there are many different well-being metrics that we could have highlighted today, but Brita and I chose a select number that we really wanted to bring to attention and to describe today. You've also already met Brita Roy, who's my colleague in all things well-being. And so this really represents our collective thoughts and work together. In our brief period of time together today, I hope to accomplish 4 different things. First is to discuss the definition of well-being. When we start to think about measuring something, it would be nice to start with an understanding of what it is in the first place. We'll also specifically adopt a community frame. In our work together, and then in the conversation that we're starting today, we're really thinking about community well-being. There are a multitude of individual well-being metrics that we could discuss. We've specifically wanted to scope this to thinking about assessing well-being from a community frame. And so we'll talk about what that might mean. We'll review some current measures, both adult and child measures of well-being, and then have some considerations about future measures that are highly anticipated. So first, to define well-being, I will start with saying I won't define well-being. And so there is no uniformly agreed upon definition of well-being. However, there are some pretty uniformly agreed upon characteristics or attributes of what well-being is. And we've listed them here. So well-being is fairly universally understood as a holistic construct of health. Importantly, it's positively framed. We can think of the WHO definition of well-being, and that well-being is not a mere absence of disease. And think about the positive end of the spectrum of what vitality and joy and health and vibrancy connote. And that is captured within the definition of well-being. It's necessarily multidimensional. Here in this picture, this is a part of a framework that Brita and I have been working on as we've been putting together a conceptual model of community action to improve collective well-being. And this is the piece of that model that specifically pictures the different domains of collective well-being as we have understood them. And here, interestingly, they are all given equal size and weight. That may not be true. We don't have really any way of understanding how much each of these different dimensions may give to overall well-being. And in fact, for different individuals, it may look very different. And yet, as we move forward, we'll see we don't really have a metric yet or a measure yet to really understand the different components and how they move towards well-being. But here you can see certain dimensions beyond the mental and physical health, but also social well-being, emotional well-being, spiritual well-being, financial well-being, and cognitive well-being. And each of these different dimensions has their own scale from disease or struggling through surviving and into thriving. Necessarily, we understand well-being as dynamic. It changes over time. It's something that as it has been measured, we have seen that that is also the case. So there's data to support that. And then not only is it dynamic, it's modifiable. We assert that it is modifiable and that we can intervene and we can change it. And then increasingly, it's being understood as a comprehensive indicator. And it's starting to be utilized within systems, within policy, as a comprehensive indicator of health of an individual or of a community or population as a whole. Now, as we move forward, we're going to adopt a community frame. And for that, we're going to talk about first a definition of population health or population well-being. And we're very familiar with that concept in that there's an average of an outcome within a population and a distribution around that. And that's a comfortable place for us to exist in, and it's a way for us to use metrics in a very understandable way. We want to, though, move towards thinking about community as not only the average and the distribution of an outcome within that community, but also think about the connections that exist amongst the individuals within a community, thinking about community as a living organism in and of itself, and that there's a group level construct that if we really want to measure community well-being, we would be able to measure something that is between people, among people, created by the connections between people, that is more than just the average and the distribution of something within the population as you aggregate the individuals. I can tell you we don't yet have a metric for that. What are some current measures, though, that we do have or are being used right now purportedly to measure well-being within communities? I'll mention 4 adult ones. The well-being measure for the 100 Million Healthier Lives initiative, that being used for Gallup Healthways well-being. 5, the Robert Wood Johnson Foundation Culture of Health metric. And then I'll introduce you to the Data Haven Wellbeing Survey. And then for children, I'll briefly mention the Child Wellbeing Index, the Child Opportunity Index, and the National Survey of Child and Adolescent Wellbeing. 100 Million Healthier Lives is an unprecedented collaboration of change agents with the goal of creating 100 million healthier lives by 2020. And Brita and I were brought in a year and a half, 2 years ago, into the metrics team and asked to figure out the measurement framework and system and by which we would measure 100 million healthier lives. We started with the question, what is a healthier life? And our team decided that we would define a healthier life as one of greater well-being and/or greater longevity. And so we went forth then with creating a model or a framework for what we would be measuring within an initiative that is creating 100 million healthier lives. And on the left, you can see an image that has health and well-being really highlighted. Importantly, the other 2 components are equity and sustainability, and that those really are also very key components to any effort to improve well-being. But I'll leave that well enough alone right now because I'm supposed to be speaking about well-being metrics. So for well-being within the 100 Million Healthier Lives initiative, they have chosen 4 domains. And this was an adaptation of the WHO definition of well-being, which included mental, physical, and social. And then we've added spiritual, which is really looking at meaning and purpose within one's life. And so those are the 4 domains that we have chosen to include within the construct of well-being within the 100 Million Healthier Lives initiative. Importantly, we've also included life expectancy. And we have created a measure for each of these domains for well-being overall and then for life expectancy as well. And then we have created a composite index, which is new and we are just beginning to test. We named him WALLY, Well-Being Adjusted Life Years. So we look forward to telling you more about WALLY as we start to utilize him more and more within our work. In order to measure well-being, we created an assessment initially for the adults in which we have a 7-item survey, which is using items that are pulled from validated scales or are validated on their own into an instrument. We were limited. You can imagine the conversations that we had as we fought for, well, can we have 8? Can we have 10? Maybe 12 items? Oh, we'd really like 15. And no, we were held very, very much to 7. In fact, that was pushing it. And that we're looking to measure 100 million healthier lives through a community-based action. So this needed to be an eminently usable, understandable, accessible, and enjoyable survey to complete. And so we have 2 items. We're using the Cantrell's Ladder Life Evaluation item as our measure of overall well-being. That's the first 2 questions. And then we have 1 item each for physical health and mental health. 2 items for social well-being, and that we're measuring social support as well as socioeconomic well-being. And then the last item is measuring meaning and purpose in life. This is now being utilized in the approximately 100 communities in the 100 Million Healthier Live initiative to date. We are aiming to have this deployed in well over 1,000 communities, as well as in non-geographic communities such as the Veterans Administration and other large interest-based communities. The Gallup Healthways Wellbeing 5, this is another measure. So back in 2008, well-being Healthways created through a very rigorous method that involved folks such as Kahneman and others in creating a survey-based measure of well-being. It's an adult survey, 55 items, that initially mapped to 6 different domains. In 2014, they adapted that survey and those domains into the 5 that you're seeing there: physical, purpose, social, financial, and community. And currently, they have a contract with Gallup, in which Gallup is calling through random digit dialing 500 to 1,000 adults a day across the United States in both English and Spanish on landlines and cell lines in order to get a sample which is essentially representative of 98% of the American population. And they're using this measure, which is the survey measure that loads to these different domains, and tracking it over time. And they're also currently implementing those measures within their blue zones, which are areas in which they are heavily investing in community interventions and then oversampling within those populations to see change in well-being over time. This measure of well-being is also measured at the individual level, and then we're aggregating that up. Importantly, though, they do have this community domain in which they're specifically asking individuals to reflect on the community within which they live, and so we're beginning to get closer to what would be, say, a group level or community level construct. Some downsides of this measure: it's rather resource intensive in order to utilize it, 55 plus items along with a scoring scale. And then at this point in time, it's a proprietary measure owned by Gallup Healthways. This will now move into the Robert Wood Johnson Foundation Culture of Health measurement framework. This is, I think, an initiative of which we are all very aware, looking to create action within communities in order to improve health, well-being, and equity, and create a culture. And they say culture of health. Really, the way they framed health, it's much more a culture of well-being, and that it's a holistic construct of health that really honors the different dimensions of health as we've thought about them within well-being. They have these 4 different action areas within which they have measures for communities and for initiatives and for researchers to use. Really, these measures, though, are looking at setting up the conditions within a community that we think would lead towards well-being. It's not an outcome measure in and of itself. In fact, there really isn't an outcome measure within the framework, so that would be a downside of it. The Data Haven Community Index. So this is available if you're in Connecticut. And it is a survey that has also been done via phone. It is a many question long survey in which they look at different domains of life, community life, and health and well-being. And they measure both the conditions or determinants within a community, as well as some outcome measures, looking at health, but also things along the lines of life satisfaction and things that might look and feel a bit more like well-being. They're starting to utilize these measures in ways that will influence local policy and local systems. And so one of the strengths, I think, of this is that it's been a very locally driven measure in which they have created data now that is really driving local change. Downsides of it: this measure, likewise, is also very resource intensive in order to utilize, and that it has multiple different items within it. And then, of course, at this point in time, from a data perspective, it's only being gathered within Connecticut, and we don't have very many years of it. For child well-being, I pictured them all here. I'll say there's really no good measure of child well-being from a community frame at this point in time. The National Child and Youth Wellbeing Index, that provides us data, I think going back into the 70s actually, but largely at the state level, and it's typically an annual assessment, and it's using publicly available data essentially, and looking at what we think are the determinants, the very upstream determinants that we think lends itself towards creating child well-being, but has never really accompanied it with any sort of outcome measure in which we're actually assessing child well-being in and of itself. The Child Opportunity Index is somewhat of a new index. It was published in 2014 and is available online with data from 2008 to 2010. And again, it measures 3 different domains, again, really gathering publicly available data, but at the census tract in 100 of the largest MSAs within the United States. And it's really looking at indicators of health, education, economics, again, things that we think are determinants of child well-being as opposed to child well-being itself. We also selected to talk about the National Survey of Child and Adolescent Well-Being, in part because they are about to incorporate an outcome measure of child well-being. They've been measuring many different things, including many of the things we think are determinants of child health and well-being for a good while now, and they have incorporated within it some measures of health and functioning that are really important, and they are now about to include measures that look and feel more like well-being measures. The downside of these measures is that the National Survey of Child and Adolescent Well-Being is specifically focused on children that have been engaged in one way or the other with Child Protective Services. And so it's a very particular very important, but a very particular subpopulation within the United States. But this measure is being utilized to get a nationally representative sample of those children. With that, I'll say thank you.
Fantastic, thank you so much. We just have a few questions now. Maybe I could ask whether the other panelists have got any particular points or responses they want to make first, give them a chance before opening it up.
We'll let the audience.
Okay. Steve.
I'll try this.
Maybe I should bring this one round.
Run around the room with this one. Okay, 2 points I want to make quickly, only because I wonder whether the subsequent speakers could react to this a little bit also, but I'd be interested in your thoughts about that. Community well-being, I think we have to be careful with that. Because I hear it being used in 2 different ways. One way of thinking about community well-being is the well-being of the people in the community. So you're rolling up the well-being of all the individuals in that population, and that total is what we might call community well-being. Or do you mean the well-being of the community, which many people would argue includes things like the economy in the community, clean air and water, good schools, and so forth. And there are different indices for those. So we need to be tidy about distinguishing between those. There are a lot of opportunity indexes out there. There seems to be a movement. We have one in Virginia that we've developed. There's a new one in California that's been developed, and so on. So we should be mindful of that. But the other thing I'd like to just throw out is we're having this panel on the premise that we need to have some metrics for well-being, which I think we do. And we all agree that overall well-being is important. But I wonder how useful it would be, and I just want to use a quick analogy. Imagine I were clicking on a card in which all you had on the instrument panel was an overall well-being index for how your car was performing. And you said, well, I don't know what that number means on there. And so, well, it's an aggregate of your speed, your fuel level, your odometer. We've done away with all that. We've done principal component analysis. We've now got it down to a number. How useful would that be? You'd say, I'd rather not have that. I'd rather actually see each of those numbers. Especially if I told you that Ford calculates their index differently than Toyota. So when you get in a Toyota, it may not look the same. That's the number. So I think you have to have both. But I think we need to be careful of how much effort we put into creating a composite index when the individual components may be the things that are actionable.
Yeah, all very excellent points, and I speak first to the tidiness.
Could not agree with you more, and in fact it becomes very difficult to be tidy at this point in time, and that many of the measures we have available to us to try to get to and approximate something that we think of as community well-being are really these population level measures that we're rolling up from the individual. And there's something important in that. And then there's also this other element of what is the community independent of, or in addition to, or beyond the sum of the parts of the individuals within it, and what are the important elements within that. And that's a space that we're absolutely wanting to explore. And to push beyond that, I would say not only are the domains and the elements that all feed towards whatever this fabulous composite is, we don't really even understand what are the elements that really load upon well-being, and then to what degree are each of those influential. And so there's so much to be learned in keeping those, even just defining the domains, and you can certainly speak to the messiness with which there is to the domains themselves. So in complete agreement, and there's much good work to be done.
Steve, we just found that in a longitudinal study using different well-being measures, some get better and some get worse. So it makes your point rather well that, you know, we just don't know what we're measuring. There's lots of people on to speak. There's absolutely no time for anybody really to speak because otherwise we're going to get nowhere, because Delia, who's our next speaker, has to go at 3:30. So I'm actually going to guillotine you now and ask you to save your questions briefly after Delia, and then for the panel more generally when hopefully we'll have a bit more time. My apologies for doing that. Delia, thank you so much. I first met Delia some years ago when she gave me a fantastic introduction to the centre here, and it was a great pleasure to meet you then, and lovely to see you here again. Yes.
Okay, thank you very much. So I really am talking much more about the individual level. So I'm going to talk to you about metrics for inpatient integrative medicine. And let me tell you for a second why I would be talking to you about that. And that's because at the Center for Integrative Medicine at the University of Maryland, we have a fairly unique, perhaps very unique as far as we know, inpatient integrative medicine service that functions sort of like a palliative care service. So rather than being the model that some other places use that's more of a menu model, as in let us know if you'd like a massage, let us know if you'd like acupuncture, we function more as a palliative care service does, where we do an integrative assessment and choose an interdisciplinary treatment plan with the patient, but for and with the patient. And that's our nurse practitioner, Blaine. Okay, so the way it works, I'm going to tell you a little bit about the service first, so you have some background to why we talk about the metrics that we're going to talk about. The way it works is we require actually a physician consultation, just like you need a consultation for neurology or cardiology or palliative care for an integrative medicine consult. And the kinds of patients we tend to get, you will not be surprised, are the ones that are making the teams crazy, right? The ones who can't control their pain, we can't control their anxiety, they're screaming all the time, the families are agitated, patients are agitated. It's all a mess, call integrative medicine. That's how it generally goes. But we like that because those are the people that we can do the most good in. Our team is interprofessional. I'm the medical director at the moment. We have a nurse practitioner who does most of our integrative assessments. We have an acupuncturist. We have a couple integrative nurses. We have some therapeutic musicians, and we have a mind-body specialist who's also an artist, and she does a lot of therapeutic art, which has really surprised me at how effective it is. And sometimes when the patients are stuck, she's the one that makes the most difference in helping them figure out what's their bridge to coping, to tolerating, to starting some sort of self-care practice. Often the art kind of unlocks something that the rest of us aren't able to unlock. And I was really surprised by that because I didn't really get that before at all. Our patients on the service generally run somewhere between 35 and 60, and it's gone, as you'll see in a second, steadily up. So what kinds of patients do we see? We're all throughout the hospital. We have a very nice relationship with the shock trauma service, the shock trauma attendings. So we see a lot of shock trauma patients. But what tends to happen is we add more units because somebody will, hear that, oh, for that kind of patient, you should call integrative medicine, and then we help. and then they start calling us for all the rest of their patients too. So the service has been increasing, which is great on the one hand and terrible on the other hand, because taking care of all the patients requires resources which are challenging to come by, and that's part of what we'll talk about in terms of metrics. We see also a lot of organ transplants, solid organ transplant patients, and then bone marrow transplant patients too. We're on the ICU and CCU units and the NICU and PICU, so we see a lot of pediatric patients, some cardiology patients too, a lot of lung rescue. Those are the people who've had transplants and they're failing and they're trying to save them. So here are the things that we offer. What I think is really important is we start with an integrative assessment. And this is new. The way we used to do it, what you started with kind of depended on who was there that day. So if the person who did a lot of Reiki happened to be free, you got Reiki. If the guided imagery person was free, you got guided imagery. And we decided that really some of these things work better in certain circumstances than in others, and it would be better to have someone who's familiar with all of it do an assessment of the patient, make a treatment plan, just like we do in conventional medicine, and then implement that treatment plan. And our treatment plans are very different depending on what it is that the patients need. But they have these options. Everybody gets the integrative assessment by the nurse practitioner, but they may get acupuncture, they may get guided imagery or meditative or relaxation breathing, they may get music or sound, they may get aromatherapy. We do a lot of therapeutic dialogue when we're helping people learn to cope with their illness, and we get people, like 19, just became paralyzed. Young father, just lost both his legs, that kind of thing. So we get really acutely, severely ill people who have tremendous transitions to make in how they see themselves as human beings. And the reason that I say that we run it sort of like a palliative care team is palliative care is the one place in conventional medicine where you really get integrative medicine, right? Hospice and palliative care, they see you in a mind, body, spirit way, but you have to be kind of at the end of life to get it. So that's insane, right? Why would we say that somebody with end-stage cardiovascular disease needs a mind, body, spirit approach, but a 19-year-old who just got paralyzed from a diving accident doesn't? And that person can't get palliative care because that's not an appropriate consult. So they consult us. So we do the same concept, so we're sort of like palliative care for everybody else. That's how I see us. Okay, so what else might you get? We started adding things as we think they're appropriate, as we can train our folks, and then we try it out and see do patients like it. So emotional freedom technique, EFT, which is a little weird, maybe. Tapping, I don't know if you've heard of that before, it's a little weird. Uses acupressure points and some cognitive behavioral stuff, but it gives people something they can do themselves, so it trains self-efficacy. And for the right kind of patient who kind of feels stuck and needs some self-efficacy, it's great, and for those patients, they love it. So we arranged for training for the staff, and now they offer it on the service. Tomorrow we're learning about microcurrent therapy, which we're going to try for people who have pain that's uncontrolled. So we're adding our modalities as we think of things that we think might be useful, and then training all of our staff. We do also pediatric massage. That was something new that we added that has become everybody, all the parents love it for their kids. We do lots of therapeutic art, journaling, Reiki. M technique is also a type of minimalist massage that we can do for adults. More and more patients we keep seeing, which is great, particularly because they require consultations. So what I get from that is the attendings think we're helping. The medical team thinks we're helping. So what do we treat? All kinds of things, but these are the biggies. Pain, both acute pain, but we have a lot of acute on chronic pain. So people had chronic pain, chronic back pain, then got in a car crash, now acute pain, or now got surgery, have acute pain. What to do with that? That stymies the team a lot, particularly if they've had some addiction issues in the past. Tons and tons and tons and tons of anxiety, both state anxiety and trait anxiety. So we have a lot of anxious people, but then a lot of the people who come into the hospital with these terrible things may not really have been anxious people, but they have a lot to be anxious about right now. Maybe they're about to lose their leg, we're trying to save it, we're not sure, right? Or maybe their whole life has changed, they don't know how they're going to support their family. So we deal with differently people who have sort of things to be anxious about versus people who are just anxious people. It's different. It's hard to sleep in the hospital for multitudes of reasons that I know lots of you are working on. But we do what we can. When the issue is rumination and fear and anxiety, we can help with that. And also, just like in palliative care, we see that the unit of care is the patient and the family together, because if the family member is super anxious, the patient can't sleep, and the patient's way more anxious and the patient's pain is higher. So we treat the family, and sometimes we only treat the family. So we may have a patient who's in a coma, for example, but get consulted because the family is really agitated. In that case, really, we're mostly treating, almost exclusively treating the family. A lot of people, because of the terrible things they're going through in the acute care hospital, have things to cope with. And so we do a lot. That's where we might do more therapeutic dialogue, where the art works better. So if someone has something really difficult to cope with, like we're not going to be able to go back to work now, you're not going to be able to work, maybe you're dying, just doing relaxation is not really what they need. They don't need necessarily just relaxation. They may need to do some processing to find out sort of who are they internally so that they can cope with this new life change. So we use various modalities to get into where we can reach the patient so that we can help them move along that process. And then we see lots and lots of addiction, intermixed with pain and anxiety and surgery and traumas and all kinds of stuff. Lots of people who have traumas also have addictive issues. Okay, so this is getting us to metrics. Payment model. So this is great. We have such a wonderful team. That's great. Everyone should have it. But how the heck do you pay for it? So that is the problem. We've changed the team a little bit to try to address this issue by hiring a nurse practitioner and an acupuncturist who can theoretically bill for their services. And we did that, thank you, with the help of the Institute. We are so grateful, who covered salaries temporarily till we can get our billing up on board. So for those people, physician, nurse practitioner, acupuncturist, we can bill. That's great, but how about all those other people, the nurses and the mind-body tech and the therapeutic musicians? We can't bill anything. So right now, the hospital, and for us, is paying for some of their salaries, but not every hospital will do that. So how do you do this? And this part of what we're trying to figure out is, what's the model that ought to be there? Should we just have billing practitioners and have no integrative nurses? Are there ways we can help convince the hospital that they ought to support this? We're going to get there in a second. That's what we're trying to do. Obviously, other programs use grants or philanthropy. We're trying to engage everybody in fundraising efforts, so we've had a silent auction so that we can buy art supplies and that sort of thing. We're trying to engage all of the practitioners in looking for grateful patients. If anybody says, oh, I wish I could help you, we're going to go right after those people. You can. We'd love to tell you how you can help us. We have discharge packets that we send home with the patients that include ways that they can help us, including financial ways. We also, by the way, this is just an FYI because I think it's important, we have a discharge prescription for each patient, so your particular wellness plan written down, gone over together, and signed by us and by the patient, just as a way to facilitate behavior change. Okay, so some places charge patients for services. We do not do that. So everything is free to the patient, but that is another potential way that you could fund such a thing. You could charge the patient. That has its other issues, of course, in terms of equity. Okay, so what are the kinds of metrics in a program like this that you could look at? You could look at clinical outcomes, because if we don't do anything good for the patient, we probably shouldn't be trying to fund such a thing. So you could certainly look at clinical outcomes. You can look at patient satisfaction, and at some point, it's possible we might have to decide if patients like it, but we can't show actual clinical outcomes. Is that good enough, or is that not good enough? We can look at medical team wellness, because we find that the medical teams of the patients we're seeing do better by Gestalt. And that's because the patients we tend to get consulted on are the ones who are kind of causing a ruckus and stressing everybody out. And when they feel better, the nurses feel better, the doctors feel better, everybody feels better. And then, of course, importantly, I think, our financial metrics, because if we're going to convince hospitals to pay for this, it'd be great if we could show them that it's actually in their best interest to pay for it. That's what we hope we will be able to do. So this is not an exhaustive list, but what are some clinical outcomes you could look at? There's a gazillion of them. Some of them are obvious because they're the conditions that we treat. Pain and anxiety and sleep, nausea, cravings for people who have addiction issues that are either being withdrawn in the hospital or are worried that they're going to get reactivated. So we have a fair number of people who are super anxious because they used to have an addiction, they got off whatever their thing was, now they had a car crash and now they're back on narcotics and they're very anxious about that. So cravings and addiction issues we often use acupuncture and other things for, and of course perceived stress. But then there's all the other individual metrics which I know people have referenced today, but we could look at resilience. We could look at post-traumatic growth. We could look at inflammatory markers and gene expression, heart rate variability, lots of clinical outcomes that one might look at. So patient satisfaction, I think, is really important, particularly because it's mixed up in a lot of other things, including malpractice litigation. So there is evidence that patients who feel like their physicians communicate with them better are less likely to file malpractice lawsuits. The one thing we know from hearing from our patients is that they feel from us that we really listen to them, just like all of your patients do. And so is it possible that that decreases malpractice litigation? If so, for a self-funded hospital, just that could be a reason that they might want to fund it. So that's something I think is important to look at. Testimonials, we wouldn't classically see as important, but I did just want to show this one because sometimes they can be meaningful, perhaps particularly if you're looking for philanthropy. This was one of our patients who lost a leg. He says, while riding my motorcycle, I lost my leg and almost lost my life. I was admitted to shock trauma. He had 20 surgeries. At some point, I was introduced to integrative medicine, and I was blown away by how much it helped. People in this field are nothing short of amazing. They spend the time with you. They educate you. They care about you, not your specific injury. They care about the whole you, mind, body, and soul. So I know it's just a testimonial, but there's something to that. So I think we shouldn't blow them away. You know, we shouldn't say, who cares? So in our discharge packets, one of the ways that we ask patients to help us is if that they want to share just a testimonial, we would love to have that too. So we're not just asking for money, we're asking for anything they want to give, including something like that. So medical team wellness, right? We can look at clinical outcomes, we can look at patient satisfaction. We can look at medical team wellness because happier patients make happier clinical teams, and happier clinical teams make happier patients with less pain, less anxiety, causing less trouble, right? And the other thing is that if you're playing harp music, if you're doing a meditation, often other people are listening. So sometimes when the harp is happening, one of the nurses will come and do their charting so they can listen. Or if we're doing a meditation in the room with a patient, the nurse will come in and do her work then. So just by doing these things in the vicinity of other healthcare workers, we impact them. We do also occasionally impact them on purpose, but even when we're not specifically going after them, we impact them. And we also model for them what you can do. So if a patient's throwing a tantrum and agitated and upset, and our team comes in and calms them down using mind-body techniques, and a nurse sees that, well, we've just done an amazing educational intervention there. So we could look at medical team wellness, even if we weren't intentionally going after them. We could look at absenteeism and presenteeism and perceived stress and their own self-care behavior. So does watching somebody do meditation with a patient who can't sleep, does that change the behaviors of the nurse who can't sleep? Does she go home and do that, or he go home and do that? I don't know, maybe. Okay, and lastly, financial metrics, which on the one hand I hate to talk about, on the other hand is the most important metrics, because the only way that we can have people doing this sort of work, if they can't bill insurance, is if we can get somebody else to pay for it. And if it's always philanthropy, you're always on the verge of losing your program. And I don't think that's the ideal way. If we can set it up and show hospitals that this is to your benefit, then perhaps they will pay for it, not just for us, but nationally. That's our goal. So there's lots of things that hospitals pay for that don't directly give them money, right? They have blood draws, and they have food, and they have chaplains, for example. The chaplains don't make any money, but every hospital has chaplains. So there are some things that hospitals provide because ultimately it makes the whole thing work. We think that they ought to do that for integrative medicine, but we have to show them that first. So here's a couple metrics that are of importance to hospitals. Length of stay is one, because as you know, hospitals get paid in a lump sum now. So if you can decrease their length of stay, you can help them, but the one caveat is there is some evidence that if you aggressively decrease length of stay, you can increase 30-day readmission, which is a ding against the hospital. So you don't want to do that. You don't want to kick people out sooner than they should be out and then have them come back to the ER. So the place to target that are conditions or hospitals or units where the length of stay is longer than the average. So, if across the board people are staying 3 days for that, in your hospital they're staying 5 days for that, the assumption is 3 days is probably enough and you guys are doing something wrong. And so for them, trying to get back to the mean is probably reasonable, but you wouldn't want to try to get below that because the patient may come back within 30 days and actually the hospital may end up losing money, which is not what they want. So length of stay, though, is a place to look if you have a long length of stay. 30-day readmission is another place. Can we impact it? We don't know. But if we could, hospitals would care about that because they can lose up to 3% of CMS payments if somebody comes back to any hospital, not just their hospital, any ER, any hospital, for particular conditions. But those conditions keep getting bigger, so that list will get bigger and include more things. The one place that I think in an inpatient integrated medicine we might be able to impact readmission is things where when you go home, if you feel anxious, you'll come back to the ER. So pain, for example, maybe cardiac conditions where we say you should be fine now, but every time you get a little twinge, you feel like you're sure you're gonna die. So things where self-management and anxiety management might keep you home instead of in the ER, that would be a place that we might be able to go. I have one more slide, I think. Okay, and the last thing, probably the biggest place that we can make a difference is in the HCAHPS. So HCAHPS is a patient satisfaction survey. Most people agree it's a terrible patient satisfaction survey. It doesn't really do a good job of measuring satisfaction, but CMS cares about it a lot and it's standardized, and they base the amount of money they give to a hospital based on these scores. So hospital administrators are obsessed with their HCAHPS scores, and they look at a lot of things, including the ones that we care about, communication with your healthcare providers and pain. So they do other things like the food in the hospital, how clean was it? Well, we can't really fix that. But the ones that we can fix are pain management potentially and communication. So if we can impact people's hospitals' HCAHPS scores, that would be a way to convince the administration, look what we did for your HCAHPS scores, other things you've done have not done that, you know that has financial implications for you, you should pay for our service. So I think this is a really important place to go. So based on the HCAHPS scores, they can lose up to 2% of their CMS money. Big hospitals, 2% of what they get from CMS is a lot, right? So they really care about them. University of Maryland does not have perfect pain HCAHPS scores, as most places don't. CMS will actually publish people's HCAHPS scores and compare them to other hospitals, so it's a way consumers can look at the hospital and say, this one looks better than that one. So there's a shame factor in there too, which they did on purpose, I'm sure. We know that inpatient integrative medicine, or integrative medicine in general, can impact pain and communication. We know that they care about that in the hospital, and that has financial implications. And we know that inpatient IM teams need more funding. So I think this is #1 place to go. Let's try and show hospitals that we can impact their pain and communication HCAHPS scores, then go to hospital administration and ask them to fund these teams and help patients with their pain, anxiety, sleep, coping, and their family, and all of those other things that we talked about. And I know I'm out of time, so I'm just going to share this last quote from, this is our big honcho trauma surgeon, who really has bought in to the importance of the mind, body, spirit care of the patient. Thank you. I'm done.
Thank you so much, Delia. Can I just check with you? You need to go about 3:30. It's 20 past.
3:30.
3:30. So what I suggest we do is that any questions for Delia, obviously ask them now, because you're not going to get a chance after 3:30. So Fred.
I love what you do. I didn't know you were doing all that stuff. It's phenomenal.
You should come and...
Yeah, well.
Well,
Your patients that you're getting are kind of like our brain injury center patients, are like worst of the worst. We call it the NICO. And we get them in, we take them for 4 weeks, we get them better. We have found that with those patients, you must fix sleep first, you must fix pain first, and you must get them off their psychoactive drugs. So in your general hospital setting, how do you handle those imperatives in this type of patient?
pain and sleep we can work on. Getting them off their drugs, we really can't. Because, let me get back to those other ones in a second. The one thing that's really important, we think, is that we have to be accepted by the medical teams. Right. And so we're super duper extra double careful to not imply that they're doing anything wrong, that we know better than them, that they should stop all those toxic medicines so they can do it the natural way. Because if we tick people off, then all of a sudden we won't have any consultation. So we can't really work on that one at the moment, although the long-term plan might be education. But we do a lot of things for pain and sleep, and they're related. So a lot of people can't sleep either because they're anxious or they have pain. So we pretty much hit everybody who has anxiety and pain. Most of the time, their sleep improves just by the things we're doing for anxiety and pain. Sometimes, though, we will talk to the nurses about, could you not wake them up in the middle of the night? Can we make sure that we put them in a room where it's quieter, they're really having a hard time? Can we turn the lights off at a certain time so that we can have some sort of a circadian rhythm that's healthy for them? But most of the time, it gets better when we manage their pain and sleep. And part of how we manage their pain is by teaching them about central sensitization and the newer thoughts about pain and the connection between threat and fear and pain, so that they can help manage their, oh my God, what if it gets worse? What if they come in? Oh my God, which of course escalates their pain. So we do a lot of pain education and then give self-efficacy. So we teach them, if you escalate like that, it will make your pain worse. So here are some techniques to not do that. And here are some things that you can do here. Your loved one can help you with them. You can do them when you go home. And we personalize them to the patient, because what we find is people are very different. So some people don't want to be touched. Some people don't want to do guided imagery, but they really want M technique, which is a hand and foot massage. And they don't want to just wait for us a couple times a week. They want us to teach their families to do it so that they can do it twice a day, or they can do it right before sleep. And so we figure out what is, for this particular patient and family, what is the way we're going to get them to the place of decreasing their catastrophizing, decreasing their generalized anxiety, giving them self-efficacy for pain control. For this particular person, what is the best way to get there? And then we make a plan for them. And then, of course, circle back and make sure it's working. And we also meet once a week, just like a hospice team. And all of the people on the team meet with me, and we go through all the patients and talk about all the patients. So how's it working? Well, I tried this, but he didn't like that. He likes imagery of this, but not that, so that all the team learns from all the team. But thank you.
Thank you. Yeah.
So right now in the ICU literature and in the hospitalization literature, there's this emerging understanding of a post-ICU syndrome. There's post-hospitalization syndrome, and really thinking about the damage that we do just simply through the act of being hospitalized post-hospitalization, and at the same time counter that to the idea we would like to get people to better, and then better than they were. Like, it would be wonderful if someone could come into the hospital and then learn skills and things such that they're on this trajectory to a post-traumatic growth even. Exactly. And it'd be wonderful, as you're thinking about metrics, to think about how what they might be learning in those crisis moments could translate into that type of experience post-hospital. Do you see decreased post-infectious syndrome in that population? Do you see less post-hospital syndrome? And then even better, do you see greater resilience and hopefulness and things as a result?
That's a really great point. It's actually one of my personal interests is the prevention of PTSD, which is basically what we cause in the hospital. And even better than that is facilitating post-traumatic growth, which I think we're probably doing, but I don't really know. It's absolutely something that we need to look at. Thanks.
Yeah, I think that's a great idea. I've got a couple of comments of my own. The first one is, forgive me, but as a foreigner, I think we need to remember that financial systems are very different in different countries. So if we're thinking of a global approach to the assessment of integrative care, we can't use US-centric financial issues alone. But the second comment I want to make is that I think the idea of the fact that this approach, which is inspirational, I think it's terrific, that this approach actually has real benefit to the staff. I think that's a wonderful idea to pursue, because burnout and sickness is such a colossal problem now worldwide. And if actually by a different model of care you prevent that, that would be fantastic. Of course, the financial implications of that probably outweigh all the other things you've been talking about. So I think that's a just terrific idea to pursue. So thank you.
And I would say that I don't have yet data to back up what I'm about to say, but we will often see really upset, agitated patients. And when we talk in team, the nurse will say, that patient's nurse is so burned out and has so lacking in empathy. And this is what I heard them say to the patient, which totally inflamed the patient. And then they were super agitated and their pain got worse. And so sometimes our treatment plan actually is, please go treat that nurse. Yeah. And the patients will sometimes get better by us treating the nurse.
I'm a family physician, so I was listening. I love the talk, by the way, but I was listening it with, through the lens of primary care practice and thinking about whether you've given any thought to transitions of care. So when you discharge this patient, and with the hospital's concerns about bounce backs and readmissions and so forth, to think about a system where some of the discharge summary and treatment plan coming out of the hospital could be picked up by the primary care practice. And obviously the obvious problem with that is that they don't know how to do what you do. They don't play the harp and all the other things. So capacity building for them so that they could offer some kind of analogous support or even group visits to help with this kind of thing to reduce the risks of admission. And then the other second question is the ED, the emergency department, A&E. Could you think about, or have you thought about putting teams into the ED? You do, okay.
But the first thing you said made me think we should add something, which is we really could give the patient something to give to their primary care doctor, just to say, this is what helped you, this is what they might support you in. That never occurred to me, and it's a great idea.
I think
We'll do that.
scenario would be, it was great in the hospital, they did a great job. You guys, you're not helping with, coping with this.
Right, no, that's a great point. I think we can communicate through the patient until the system gets bigger.
Okay. Last quick question, Judy. Have you got a machine? Why don't you use this one?
Information. Thank you so much. I'm curious, you say you use therapeutic art. Do you use artists to do these interventions, or?
Our mind-body tech is an artist.
Oh,
and she
okay.
has done a tremendous job of teaching all of us and looking up various ways, new ways that she might help the patients. And one simple example I'll just give you is that the person's really stuck, so they won't participate in PT, the nurses are getting mad at them, they're not doing what they're told to do, and they're like, oh, they're being non-compliant. And we'll go see them and say, they're just stuck, they're sort of flat, they don't know how to move forward now that they don't have legs or whatever. And she will sometimes go and do an exercise with them where they draw a big hole, and they're over here is a crater, and she says, how are you going to get over there? So you're here, here's a big crater, how are you going to get over there? Draw it for me. Or if you don't want to draw it, describe it to me. And patients say the most amazing things that then kind of open up their own mind about ways they might cope. So they might say, well, I draw all my friends and they'll make a bridge for me to get over the big hole. Or sometimes they'll say, well, I grabbed my cats with me and they jumped me over, right? So, I mean, just from hearing those two things, oh, well, this person we need to talk about their social supports, and how is your social support going to help you, and how are you using this person we need to talk about their animals. So just one small example, and she's a master. She's not an art therapist, she's an artist, which is why I said therapeutic art. She's an artist who also is trained in mind-body medicine, so she combines the two things together in a really artful way.
That's wonderful, thank you.
In many ways, this presentation is still very relevant to our discussion, and really it was about sort of this idea of what's the future of wearables. And one thing that's exciting for me to see is that in the Silicon Valley, a lot of people are beginning to believe that the future of wearables is about behavior change. So Jawbone is a company that makes a device that many of us would call sort of a fitness tracker. It looks like this, and here's their mission statement. But really sort of speaking to integrative health, they conceptualize what they do is that, they're building this integrative system, right? So you have your band, but it goes far beyond simply sort of a simple device that counts your steps. It's connected to an app. The app can connect to many other partner apps, and so it can draw in all this rich data. And then we're learning about users over time and using what we learn to give people tailored feedback, especially for them. And one of the main goals is to give meaning to their data, right? And to give meaning to their data in a way that motivates them. And so here's an example of some of the kind of data that we have to work with at Jawbone. We measure people's steps, their sleep, they can input meals, and we can get meals from other partner apps, mood, and all sorts of things. And one of the challenges for me moving to Jawbone has been, how do we translate all this knowledge we have about sort of what works in therapeutic settings, one-on-one interactions or sort of group settings. And for those of you who don't know, I was actually trained as a clinical psychologist, so most of my training has been in those settings. But then translating that to an app is just a whole brave new world, right? And there's no rule book for this. So the place that I started at is this question, what matters to our users? Or for you, you would think of it, what matters to our patients, right? And as a psychologist, I think that's sort of where you should always start. So in one of the surveys we sent around, I managed to add a question, some questions about weight loss, and we found, lo and behold, that 84% of users are actively trying to lose weight. And many people think that people who buy fitness trackers are probably, really fit and look like all the people in the ads. But indeed, the user base looks a lot more like America as a whole. And in fact, it's a very international user base. So weight loss is important to our user base. And of course, many of us already know that we should decrease calories and exercise more if we want to lose weight. But the key thing is it's not about giving someone knowledge, because knowledge is not enough. And most of you already know this, that obesity has become such an enormous problem in America and worldwide, but I still always find these stats so striking to see that in the space of 25 years, prevalence rates have gone from being about 10 to 15% in most states for prevalence of obesity to now, approximately 1/3 of the U.S. Qualifying for obesity, and about 2/3 being considered overweight or obese. And for the first time in the world as a whole, overweight and obesity are killing more people than underweight. So that's why it definitely so the trends are really dramatic. And what's also very interesting is that there are emerging reviews of the scientific literature that show some promise that through these kind of monitoring systems, meaning some sort of tracking device combined with an app, that indeed they really help people lose weight. So, for example, in this review, group weight loss alone, or group weight loss sessions alone, help people lose about 4 pounds in 9 months, but the combination help people lose almost 15 pounds over 9 months. So as a psychologist, when I think about sort of how do I help users? How do I give them back their data in a way that has meaning? What is the framework under which I can sort of build all of my ideas from? I sort of think about self-regulation, which I'll define here as the ability to act in your long-term best interests, aligning your behaviors with your deepest values, and the ability to govern your actions. And so on the left is the model that Jawbone often uses to sort of conceptualize what they do. So they'll talk about how we can track data from users and we feed it back to them in a way that helps them really understand their actions and their data. And from that understanding emerge changes in action in a kind of feedback loop. So that one of the ways this system is so different from traditional psychotherapy is it's not an intensive hour of one-on-one. It's kind of like a nudge system that you carry with you throughout the day. And it gives you a tiny nudge here and then a tiny nudge later. And it's the sum of all these tiny nudges that adds up, which is it's also a very different concept than a psychotherapeutic conversation. And then from neuroscience, I think it's useful to bring in our understanding of what happens when self-regulation fails, and why does self-regulation fail? So, inside this kind of black box of the brain, you have reward circuits and you have threat circuits, and then you have sort of the prefrontal cortex regions that inhibit and help manage or regulate reward drives and threat drives. So self-regulation failures occur when, this integration isn't happening quite the right way. And when we think about kind of this framework, we can see different categories, right? And there are metrics that align with identifying these categories in a kind of big data setting. Because when you think about it, if you're looking at app data, what do you have? You don't have the patient talking to you. You have kind of, I like to think of it as an iceberg or a glacier where there's like a small part above the water and then most of what's going on is below the water. So the part that's above the water is basically behaviors that you can see the user doing, whether it's, you can see them sort of looking at different insight cards that you give them on the app. You can sort of see that you have a data point that indicates that they saw something you gave them, or that something was generated for them, that they logged a certain action. So somehow you have to take their behaviors and their interactions with the app and infer from that everything that's below water about this glacier, and that's quite difficult. So I kind of put it in a framework where sometimes I think about rewards or threats and when self-regulation is highest or lowest for a user, and then how we can intervene upon that. And then I just like this picture. So in terms of self-regulating your ability to eat food, there were these classic studies called the marshmallow test, right? Where they give kids a marshmallow and they say, if you can sit in a room with this marshmallow and not eat it for, I forget, 10 or 15 minutes, when I come back, I'll give you another marshmallow, let's say. And, it's very hard for these little people to avoid eating the marshmallow. And, I think most of us actually sort of have this little person inside of us all the time. And this is kind of what we're going through in our daily life, right? But the marshmallow test turns out to be predictive of some amazing things in terms of educational attainment and body mass index later in life. So it goes to show that self-regulation skills are just so important as a focus. And they are something that I think people can build over time through interactions with the nudge system. So now I'm going to kind of put all this in context and talk about some experiments that I've been able to do on weight loss at Jawbone. And just to set the stage, so in general, our users do tend to lose weight when they get into the system. And so here we've looked at users who set a weight goal, and that's about 72% of all users. And you can see that over time, they are losing weight with the product. Although not a huge amount. So 62% of our users do lose some weight by 12 weeks, and about 50% of them reach 25% of their weight goal. Now, many people set pretty large weight goals, so that's not bad. So the next thing I asked, because I tend to think in I have a little bit of an engineer mind, actually, so I wanted to identify, well, what are the levers that we could help people modify that would help them improve this weight loss. So I did this sort of multi-modeling analysis and looked at different factors and how well they could predict weight loss over time. And then I've ranked some of the factors I found that were predictive kind of by their importance. And of course, people who start heavier tend to lose more weight. That's what you would expect. You need to control for that. But then, we see that someone who set their weight goal in the app, 3 months ago, does not lose as much weight as someone who set their weight goal last week. So the time that someone set their weight goal is kind of a marker of their intentionality and how present that goal is for them in their mind. So that's what I mean about being able to kind of infer much deeper psychological things from this tiny little action you can see. And then Jawbone has something called the food score that is a combination of macronutrients, and its intention is to sort of convey that food quality matters. So it's not only calories in and calories out, but it's a quality of food you eat, and a higher food score indicates better quality. So that is predictive. And then we see other things related to food, activity, and also being more engaged with the app, which is probably an indication of motivation. So we do have the capacity to do randomized controlled trials at Jawbone. And this is really critical because just showing factors that are associated with weight loss doesn't mean that they're causal, and it doesn't mean that we can modify them. So those are the key things we need to get out of experiments. And so we have our participants, and we can randomly assign them to a treatment group and a control group, and then we can give the treatment group sort of an intervention and compare it to the control. Although, really, to be fair, this is more like comparative effectiveness, because we can never give someone a poor experience. And actually, that's one of the biggest challenges is what is your control? But anyway, so here's an example of one of the RCTs that we did, where we encouraged users to log their food in the app. And we know that people who log their food more frequently tend to lose more weight. So the treatment group got this message where we tell them about sort of benefits of eating breakfast and suggest that they log their food throughout the day, versus the control, we wanted to give them a message that was also food related, but didn't have that call to action to log your food. And so then what we saw was that the treatment group indeed had a higher likelihood that they would log their meal subsequently. And of course, one of the other things that was interesting in this experiment is, yes, we saw people were more likely to log their meal, but then we also saw that in some cases, the calories were increasing. And so it's like, how do you make sense of that? Is that a good thing or a bad thing? So, I went back to the literature to look at sort of how people actually self-report about their diet. Because again, all we have is self-reports. We have no ground truth about what people actually ate. And what you see is with this data that people enter themselves, there's just huge variance. It does not look like sort of a perfectly clean data set that you get at the end of an academic study. And so we find in the scientific literature, people who underreport their caloric consumption, meaning like their calories are too low to be consistent with what any normal person would need to sort of survive and maintain weight on a day-to-day basis. Those underreporters actually tend to weigh more, and they have more concerns about their diet. And so, long story short, we decided that probably even if the calories were going up after we asked people to log their food, that was probably a good thing, because it means that people are being a little bit more honest about their behavior with themselves, and then they're better able to self-evaluate what they want to choose to do. So one of the roles that I've kind of taken on is to work closely with our writers to really think about what are the psychotherapeutic principles that we get to leverage. But the challenge is we have to leverage them in a very short number of words, and it has to be in the style that is kind of consistent with Jawbone's style, right? So here's an example where, especially when you're giving people feedback about weight and food, those are very sort of shame-inducing topics, and you can get a lot of backlash from users. And so we really try to help people sort of normalize and be very empathetic, and make it very easy for them to log food by giving them a link at the bottom of the screen. And to kind of subtly stress things we know from neuroscience are important. This idea that as you're logging, you are more mindful of cravings, and you're sort of building insight into your own behaviors. Okay, so I showed you the list of factors that we came up with that were predictive of weight loss, and basically then I go through and try to think of ways that we can turn each of these data insights into a product that we can give the user. And this is really important, because what I keep hearing in discussions of big data is that people say, okay, we've got all this data, and now we're going to give it to this mathematician, and then we're going to have the answer. And really, actually, data is very confusing, sometimes self-contradictory, and often doesn't have a lot of meaning when you just look at the number. And there's a huge step of translation to take the data and turn it into a product. What do you do with your data that actually helps someone? So that's kind of where I'm really placing a lot of emphasis, is what do you do with the data that matters? So in terms of time since weight goal, we sent people this messaging basically saying, hey, you know, people are much more likely to reach their goals when they feel attainable. So if you're planning on losing 20 pounds, maybe try setting your weight goal to 5 pounds. And you know, if you reach it, you can always set another one. So we got pretty good luck or feedback from something like that. And then here was another really interesting thing we did. So the food score was predictive, and also eating fewer calories per meal is predictive of better weight loss. But those are numbers that for many users may not have that much meaning. So if I tell you, why don't you raise your food score by 1 point, and why don't you eat 50 calories less per meal, you know, for me at least, that doesn't really translate into an obvious action. And it doesn't really, I don't absorb it as a message. So what I thought would be more meaningful was to really focus on vegetable consumption and basically eating vegetables at every meal, because I think that's just something concrete. You can look at your plate, does it have a vegetable, does it not? And actually this was a really difficult task from a data perspective, because people can type in any food they want, and then you can get all kinds of crazy things, and you need a program that can clean all of that and extract a number that's meaningful and predictive and accurate enough you can give it back to a user. And then also, to make it meaningful, I wanted to extract the vegetable that user ate most frequently within that time period. Because when we just give people recommendations, they'll say things like, well, I hate avocados. But if you can tell people what they're already doing right and say, hey, we know that you tend to eat a lot of broccoli, but you only eat vegetables with 20% of your meals, can you eat more broccoli? Right? That's a nudge that people respond better to. Okay, so let's see, I won't go through this, but we found, obviously, if you're going to track weight loss, because we're not bringing people in, we have to make sure they actually log their weight. And there are huge problems with sort of the introduction of selection biases due to missing data, so that's been something that I've really worked on. But in sum, basically, I do think that there's really a role for wearables and for these integrated systems in helping empower individuals. And I do like thinking of it as this integrative system where part of the goal is to get the data, but even more important is how to make meaning out of the data in a way that is motivating and empowering for the user. So my sort of final point is that I think the future of wearables is really moving away from sort of the fitness enthusiast and a fashion item to being something that fundamentally helps people change and manage their behaviors. And that, you know, psychologists and neuroscientists actually have a lot of really valuable knowledge of domain knowledge that they can bring to the table. And I hope that the future of this field has more to do with health than fitness and with prevention than disease.
Thanks very much, Kirstin. I've heard Kirstin speak 3 or 4 times now, and it's always on a completely different topic, and she's always completely on top of it, and doing brilliantly elegant experiments. It's impressive. So a few specific questions for Kirstin, and then we'll have a short period of our discussion. David, I think you were first.
Do we have a microphone?
Yeah, I have a microphone right here.
I have not gone to a conference in the last 2 years where there has been protection of our conferences or behavior change as we were. It is huge. And it's reassuring to me that people with your intelligence are doing something that data besides making marketing noise. Because it is going to be, I mean, the studies are robust enough now that wearable change.
Yeah, I'll say I was really, there's this idea in academia that, academics are pure seekers of knowledge and people in industry are sort of money driven and, corrupt. And I really haven't found that stereotype to be upheld at all. I've found that, really it's about sort of pretty similar. Maybe it's also that I'm fortunate to be in a company where they really value a product that truly impacts behavior. But I think it's very impressive.
Richard, then George.
Thanks. I have one quick question for Carley and then one for Kirstin and actually also for Delia in absentia. But for Carley, I've recently become aware that there's a very large subsection in the APA of community psychologists. This is sort of new to me, and I'm sure it's not new to you. But one of them told me that there's a fairly robust website called the Community Toolbox, which you may also be aware of. Okay, so I just wanted to encourage you, if you're not already doing it, to make your metrics available to Community Toolbox, because these are a lot of people who are working directly within the community who need these metrics, who are getting grants from community-based, who are not in the, the academic system. So it sounds like you're shaking your head that you're aware of that.
Yeah, absolutely.
And in fact, one of the great things with working with 100 Million Healthier Lives is that they are truly an initiative that is casting a really big tent. And so through that work, we've really been able to come into contact not only with the Community Toolbox folks, but also Community Commons, who are helping to build a Metrics That Matter wizard for communities to use directly. And in fact, we've been part of the design team in making the metrics selection, data collection process, and then the data analytics available to communities in a way that drives both quality improvement style initiatives in like a PDSA rapid cycle improvement style way, as well as over the long term in a more research-oriented fashion. And so absolutely communities need to be given metrics as well as ways in which to use the metrics in really meaningful ways that drive actual change. And so that's happening right now. And any of you who are involved, and I know Stephen's very involved in that work as well, please come in under the big tent of 100 Million Healthier Lives and inform the direction that's going in.
Great. And a quick question for Kirstin is, I'm not an acupuncturist, but having worked in acupuncture research and within the acupuncture community for over 10 years, one of the interesting things I've become aware of is I heard a person much more in the tradition of, rather than the TCM approach, the 5 elements approach, where they make less of a distinction between the physical and the emotional in terms of how they treat. And that is people who have problems, imbalances in the stomach meridian, can't digest ideas, interestingly enough. And they find that only when you start to improve the stucknesses in the stomach meridian can people hear really and follow the ideas that you're suggesting for life changes. So it's very interesting, and I'm obviously not all people from a Chinese perspective who have weight gain or obesity problems are going to be involved in the stomach meridian because it's a multifactorial problem. But it strikes me that there's really an important subset of people who this kind of awareness may be really valid, and the more you talk to them, it's not going to help until you can somehow treat the underlying imbalance that's causing a lot of the disorders in weight gain.
Well, I definitely ascribe to the belief, after having been a therapist who's practiced CBT, that one of the best ways to restore your mental health is to balance your sort of behavioral health, right? Like when you sleep better, when you're appropriately active, you just tend to have a better mood. So, and I think that we do people a lot of good by just helping them kind of get back in balance behaviorally. But yeah, I mean, the Chinese phenotypes are fascinating. You can't really look at them right now on the app, but maybe one day.
Right, so you could do a study where you look at
just to correlate a Chinese medicine diagnosis with people who benefit or not benefit. It would be just an
I guess
interesting
one
variable.
quick thing I'll say from the metrics perspective, because we're talking about that, there are all kinds of metrics you can get from app data that we never, or at least I never thought about as an academic. So you can see that people are more likely to engage in certain self-regulation behaviors like on a Monday, and much less likely, like on the weekend, right? So there is this self-regulation is kind of this resource that I think gets depleted throughout the work week and then gets restored. And there are time of day, time of week sort of cycles that you can pick up when you have this kind of rich data throughout the day. And I never even really thought of how that plays into metrics, in an academic setting.
Yeah. Hi, so I have two wonky questions. First for Kirstin, I was intrigued by the figure that you showed that showed increasing weight loss with length of time using the app. And I'm wondering, is that based on longitudinal data, or is that based on cross-sections of people who have used the app for different periods of time, which would tend to select for the people who are having better outcomes to be using them longer?
So the actual predictive factor there is it's the average number of insights that a person viewed a day, and an insight is like a little card you can get in the app, and you can swipe
you had a
it.
graph that showed.
So that was weight loss over time.
Yeah. So is that based on following individuals, or is that based on weight loss as a function of different groups of people who have used the app for different lengths of time?
Right, in terms of sort of the selection
cross-sectional or
biases of
longitudinal.
people who drop out.
Yeah.
We've looked at it both ways, but I mean, I have looked at, the way I model it now is within a user, their individual trajectory.
Okay, good.
Yeah, but I mean, selection biases are a huge issue in a system like this because, in an academic study, you're bringing people back in, there's a visit where you're getting their data, and it doesn't work like that at all.
Yeah.
So we've had lengthy discussions about selection biases and how it impacts our findings and what we can do to manage them.
So the other question I have is for Carley and Brita. As you know, there's a long history, there's 40, 50 years of work on measuring health, okay? And so for me, going back, I started sort of with the Bradburn-Kaplowitz positive negative feelings and all that sort of stuff. But in the early 80s, Jim Fries came out with his compression of morbidity study, which was an attempt to answer the question, are we living longer but not doing better? Are we living longer and doing better? And that was the first, and to my mind, that was the first attempt to link longevity with a functional measure. And then there's a whole set of activities that came after that with the REVS group and active life expectancy, and I forget his name, but the guy in Seattle who got $100 million from Gates, who Chris Murray, did a lot of stuff with RAND on measurement of health, and then it seemed a lot of that seems to have been replaced by DALY's disability adjusted life years, and now I take it that WALY's is the opposite side of that, but I think it raises the same concern for me. So DALY's are based on an evaluation of the value of an extra year of life to a particular individual, and typically are driven by questions like, would you rather have a broken leg for 3 years or terminal cancer for 6 months. And I think they create these scenarios for people which are absolutely impossible. People can't possibly answer them. They're totally out of their experience, and they have very little external validity. And I'm wondering, but I like the idea of the WALI. I'm wondering if you can imagine any way of getting around those kinds of issues.
I'm going to dodge the question a bit in that I'm going to say partly we're looking to honor both the component of what goes into life expectancy and then also a measure of self-reported well-being overall, and longitudinally seeing how that improves within communities over time. In so many ways, we haven't necessarily engaged in that kind of evaluation where we're setting up those different conditions for individuals to choose. We're looking at how our measure functions over time. The other, I think, there are a number of different issues that we have with looking at life expectancy. Right now, I think it's an important measure for us to look at, particularly from an equity standpoint, in that we can see that there's like sharp disparities within life expectancy that point directly back to the social determinants of health, which we are like imminently needing to take action on within communities. So in many ways, there's a pragmatic piece too. We have that data available. We know that it's going to drive really important action, and narrowing the gaps that we have in life expectancy along with improving well-being are going to be really important immediate gains that we can see hopefully over the next 10 years or so. I'll add just another concern that we have just from a pediatrics perspective in terms of looking at how a measure like a DALY or a WALI doesn't really honor what we want to honor when we're looking at child health and investments in child health. And there's some difficulties there as well in terms of investments that are really important up front. We may not be able to see the WALIs or like we have been able to see DALYs improve in the way we would like to with those. So all of that is to say there are a number of different issues with it, but I think there's some really good reasons right now.
Thank you very much indeed to all the panelists.